It's all around us. We hear about it on the radio on the way to work, and we hear about it on the news channels when we come home from work. The opioid epidemic is taking the lives of so many and preventing so many more from reaching their full potential. But we know the problem. Our difficulty is that answers are lacking. As a physician who is double board certified in both pain medicine and addiction medicine, this topic is personal. Here I offer a solution to decrease inpatient opioid use by presenting alternatives to the top 5 disease states that we encounter in the hospital. Thank you for watching this, and please pass this information along so that others can help partner with us to bring a close to this chapter in modern medicine.
Medical Specialists Associates, making medical education more accessible.
So thanks for watching. I'm Christopher Viscalpos of Medical Specialists Associates, and I'm here today to present to you the extremely important topic of ALTO, which stands for Alternatives to Opioids. So how am I going to do that? What I'm going to do is I'm going to present to you the top 5 diagnoses that present to the emergency department or for inpatient pain medicine consultations in the hospital, and show you an algorithmic approach to alternatives. First-line treatments, second-line treatments, and in some cases, third-line treatments prior to turning to consideration for opioids. So what are those top 5 pain medicine conditions that we can consider alternatives to opioids for? They are kidney stones, lower back pain, fractures and joint dislocations, headaches, chronic abdominal pain.
So we've all heard of so many different statistics on how bad the opioid epidemic, but this one really hits me the most, which is every day 130 Americans die. And this is such an important statistic that we can have an impact on because pain can be managed in a lot of ways that doesn't involve the risk of addiction. Yes, opioids will have a place and opioids will be used in certain conditions, but we can use far less of them by implementing this algorithm that I'm going to present to you now. So it starts really in the emergency department upon presentation for our providers. Our providers can immediately set the appropriate expectations by using words for patients such as we're going to control your pain instead of eliminate your pain. And we're going to make you more comfortable instead of being pain-free. Setting expectations again is so important. And next, you have to begin to know your first-line medications, and we're going to repeat these many times throughout the pain conditions that we see. And those are ketorolac, also known as Toradol, ibuprofen, maybe also known as Motrin, Tylenol, here listed as APAP, lidocaine, gabapentin, prochlorperazine, and diphenhydramine. So let's jump straight to our first condition here, and that's musculoskeletal pain. So first line are really our NSAIDs, listed here, ibuprofen. After that, we can consider Flexeril or cyclobenzaprine. Some of the benzodiazepines, such as diazepam, can also relax the muscles. And here we can also talk about sub-Q lidocaine. So what are these? These are trigger points. Very simple to do. Any physician can learn how to do them, or nurse practitioner or physician's assistant. We simply take a syringe filled with lidocaine and a very small introductory needle, maybe 25 gauge or 27 gauge, and we inject into the muscles in the individual areas that the patient is having musculoskeletal pain. The local anesthetic has many effects, one of which is it just temporarily relaxes the muscle in that area and is oh so effective. So what about second-line treatments for us? Well, we can jump to Toradol, which is a very potent NSAID, more potent than the ibuprofen. What about steroids? Dexamethasone. 8 milligrams of dexamethasone is equivalent to more than 30 milligrams of morphine. So effective in so many patients. And also low-dose ketamine. We're starting to use more of it. So at low doses, we're talking 10, 20, 30 milligrams. It has the same, if not more, pain effect as the opioids, but with a similar or better side effect profile. So what about alternatives? We can do lidocaine infusions. And so instead of injecting the lidocaine subcutaneously, here we can do it as an intravenous infusion over a period of time, as long as someone's being monitored under telemetry. Other alternatives include here gabapentin or Lyrica, which is also known as pregabalin. So let's go to our next pain condition here. And our next pain condition is the treatment of headaches. So again, first line treatments is going to be your ibuprofen or other alternative NSAID. Again, Tylenol as well. Both the Tylenol and the NSAID can be given concomitantly. Again, benzodiazepines such as diazepam can also be used for the treatment of headaches. Here we also can use sumatriptan, a very popular rescue medication. Some patients just don't have it as an outpatient, and it can be used in the in-hospital setting, in the emergency department, or other places within the hospital. Here again, trigger points, as we talked about in the previous slide. Again, so easy to learn. We can teach any physician, if not a nurse practitioner or physician assistant, how to do these. So if you had to go to second line, again, Toradol, again, dexamethasone, but here also two other medications which are very effective as well, prochlorperazine and diphenhydramine. I don't think used enough, and it's important to be cognizant of these alternatives. Then also magnesium, which perhaps maybe relaxes some of the vascular smooth muscle in the head. Again, very effective. What about other alternatives? Well, cyclobenzaprine, also known as Flexeril. Again, we could use diazepam if we didn't use it in our first line drug choices. How about here though, how about intranasal bupivacaine? So let's just take a second here and go over this one. This one's very simple to do. We can take a viscous solution of bupivacaine and put it on a Q-tip, as which it's shown here. And what we do is we put that Q-tip straight back here towards the cribriform plate. And when we put it here, that medication can diffuse into the sphenopalatine and provide what's called a sphenopalatine block. For the longest time, us in pain medicine were doing sphenopalatine blocks in other invasive ways by going through the face in some way, shape, or form to get to that sphenopalatine. Here, it's so easy. We can just use a Q-tip and just learning how to put it straight back to that cribriform plate. This is highly effective. So we could also have some patients that we don't want to use benzodiazepines for, and if that's the case, another alternative can be Atarax to use here as well. So what about fractures or joint dislocation? Well, Tylenol, very effective, PO or IV. What's also extremely effective, again, is that low-dose ketamine. Again, at least as effective as opioids, if not more, with a similar, if not better, side effect profile than the opioids. And for fractures in particular, intranasal calcitonin, very effective for that fracture pain. What about abdominal pain? So for abdominal pain, first-line medications we can consider are metoclopramide, also known as Reglan, again, prochlorperazine and diphenhydramine, but here also maybe dicyclopamine, which maybe is not as popular to individuals, and so I'll just make one or two comments about it. Here, this medication might relax the muscles in the stomach and the intestines, and is also considered to be an antispasmodic, an excellent medication to use as a first-line treatment. Again, we can use lidocaine sub-Q injections. Those are our trigger points, often very effective. Second line, we can use haloperidol. Perhaps maybe it works via dopamine receptors, maybe in the gut or otherwise in the periphery. Again, low-dose ketamine, very effective. But here also lidocaine again, and perhaps maybe not using lidocaine here again as a sub-Q injection into muscles, but here again, lidocaine used as an intravenous infusion. Very effective. Last here, renal colic. So when someone has a kidney stone, very painful, one of the things we want to do is help them pass that stone. So hydration with normal saline, very important. But what's also great is, again, Tylenol, acetaminophen, and your Toradol or ketorolac. Very effective here. Again, we also consider other secondary line medications, which could be a lidocaine infusion, which we've talked about now for some of the other pain conditions. But also another alternative that perhaps may be overlooked is desmopressin. And here I'll talk about it just in a little more depth and say that here the desmopressin can relax renal and pelvic and uterine smooth muscles. and it might also have a central effect by stimulating the release of hypothalamic beta endorphin as well. Again, very effective and perhaps maybe all too often overlooked as an option. Well, there you have it. Now you have ALTO, which is Alternatives to Opioids. Please partner with us to become part of the solution to the opioid epidemic by passing this information along. Thank you for watching. Thank you for watching. Please consider sharing your suggestions or comments with us at the email address listed. And please also continue to visit with us at our website and our YouTube channel. To be instantly notified of when we release new content, please consider subscribing to our YouTube channel as well. Thank you.